Dr. Meenakshi, and today we are back with B2B series where we'll be dealing with the oncology module. So first, let's get into the basics of oncology module before we can discuss about few cases today. So firstly, it's very important that you need to understand the basic principles of the screening for cancers and what investigations needs to be recommended for each of the cancers. Okay. For example, if there is about the cervical screening, it's very important that you need to understand about the protocols regarding the cytology, regarding the HPV testing. If it becomes positive, how do you proceed with the colposcopy? If the colposcopy shows any kind of abnormality, how are we going to manage that? Similarly, even for an ovarian cancer also, it's very important that you need to be understanding about the postmenopausal ovarian cyst guideline as well, where there is a high chance when the RMI goes more than 200. So you need to understand about the basic sequence, and all the FIGO classifications of the cancers is again very, very important. Similar is the case in terms of like screening for for the vulval cancer as well. And also for the endometrial cancer, whenever there is endometrial hyperplasia, how are you going to deal with it and all of that? If it turns into an endometrial cancer, there can be different possibilities to different stations how you can get about. For example, if a patient has come to you with heavy menstrual bleeding and she has tried some kind of treatment, and then you go on for the endometrial sampling, which has come out to be hyperplasia. It can again be with or without atypia. And sometimes it can also be an endometrial cancer. And sometimes you could have done a hysterectomy for any other indication. And there was, when it was sent for HPE, you have found out that there is an endometrial cancer. So how are you going to go about that as well? So it's very important that you need to go, at least you need to have an idea about the outline of how you're going to manage the cancer. Doesn't necessarily mean that you have to go in depth about how are you going to give the radiation and what are the cycles of chemotherapy and what are the different chemotherapeutic drugs. This is all not required in SPT. And knowing about the cancer staging, as I told you, it's very important that you need to be updated with the latest FIGO staging, and you have to be understanding, because sometimes they will be only giving you about the description of the cancer, where you have to decode like what stage that is all about, because your entire management would be based on that. And for that particular stage of cancer, and for that particular cancer, whether surgery is relevant or whether chemotherapy is suitable to her, whether radiotherapy is suitable to her, which one is going to be suitable, you should be able to judge. In details are not required, but of course, a briefing at least you should be able to give. And MDT is key in oncology, very, very important, because we are at the level of ST5 and it's beyond our scope. So it's important that you have to escalate to the MDT, where you have to involve the NHS2B referral pathway, the cancer support groups, the Macmillan's nurses, the gynaecologist, oncosurgeon, as well as a radiotherapist. All of them needs to be involved in case of an MDT. And involvement of support groups, of course, that is going to be crucial to any station, but definitely more important in case of the oncology. If you can look at the case examples, what happens is it is mostly like a breaking bad news, which can come also as a lay examiner station, like how empathetic you are, how sensitively you're dealing with the situation, and how well you're able to tell the woman that it is a cancer. That is all something that you'll be tested by the lay examiner. So it can be breaking bad news, which can be any kind of cancer. It can be endometrial, it can be cervical, or it can be vulval, it can be ovarian. Okay, these are the four most important cancers in and around the gynecology. So therefore, your questions would be revolving around these only. So it is important that you have to have a thorough knowledge about these cancers. And sometimes you will have to suggest like what further investigations you need to go about. Sometimes the investigations are already enclosed to you, so you need to speak about that. Let's say, for example, you'll be telling the woman that, she's got some kind of symptoms, and you'll tell that you would want to examine her, and then you would want to suggest few investigations. When you say that, the examiner might provide you with the investigations if it is a part of that station. Okay, so you have to read those investigations and you need to interpret accordingly, and you have to explain about the management as well for each of the cancers, like how are you going to go about, especially for cervical cancer. It could be a bit tricky because each stage the management is going to be a bit different. So how you're going to manage, whether it's surgery or whether you're going for concurrent chemoradiation, that is all something that you need to be very well aware about. And you need to be learning about the choriocarcinoma as well, which is very, very important. And then about the abnormal smears. Okay, so in the abnormal smears, once the smears come out to be abnormal, you'll be explaining regarding the colposcopy, regarding the Leeds procedure, so how the procedure would be done. And sometimes you need to explain about the risks which are associated with that, and what if the reports come out in favor of cancer. This can be an overlap between sexual reproductive health as well as in the oncology module. If it is a structured discussion, it could be evolving, like from an abnormal smear being HR-HPV positive to normal low-grade intraepithelial lesion. It could turn into high-grade, and then it could be evolving into cancer as well. We don't know. Maybe a previous biopsy was having a low-grade lesion and the colposcopy was done, and now that has come out to be cancer. Maybe this is the second colposcopy which has come out to be cancer. So it can be evolving also. So that is something that you need to be, there could be an overlap of modules. It doesn't necessarily mean that it would be only around the oncology. It can come from anywhere to and to land into oncology. So cervical cancer in pregnancy, that is also very, very important. There is a chart in the TOG article which is supposed to be very well versed with. And it is very simple and very, very easy to understand as well. And in-depth, as I told you, is not required. But for stages like 1A1 and 1A2, what are you going to do? If it's 1B1 and beyond 2A, 2B, whatever it is, you have to understand the flow chart. And it's very important that you have to memorize it, because sometimes we might not be doing it on a day-to-day basis unless we're an oncologist or an oncosurgeon. So it might be a bit difficult and tricky, but as you keep glancing it, it becomes very easier. And with repeated practice, that would naturally come with the flow. And you should be able to recognize and plan the management of a pre-malignant lesion. Let's say, for example, there has been lichen sclerosis. Okay, that could probably evolve into VIN, and that could be resulting in vulval cancer. So that is also one of the possibilities. So when you are seeing a lichen sclerosis, it is important that you will have to be managing a lichen sclerosis as well. Lichen sclerosis or lichen planus. Okay, these are all pre-malignant lesions. VIN, vulval intraepithelial neoplasia. Okay, they are precancerous. So it's important that you have to give the timely management as in to avoid the progression towards the cancer. So a few do's and don'ts in terms of oncology. Empathy is very, very important. You need to have a very sensitive communication, extremely sensitive. You need to mellow down your tone, and you need to slow down your pace, and you need to give adequate pauses. You need to give warning shots, offer support to her, and how is she going to go back home once she's taken the news. These are all a part of communication. It's not that you're giving the news that it's a cancer and then telling that, do you want me to postpone the consultation? That's not how it works, right? It's very important that you have to be extremely sensitive. Give her some time to react. Okay, if she's upset, or if she's crying, or if she's shocked, whatever it is, let her express her emotions. And then you proceed with the consultation and just go with the flow rather than preparing that I will talk this, I will talk that. Just let it go with the flow. Like, you don't know how the rotator is going to react. So please make sure that you go with an open mind and just react to whatever the patient is trying to say. And giving a support, as I told you, like when you give the warning shots, either offer support from your side or ask her if there is somebody along with her. So giving support so that, she'll be having a bit of warmth with somebody around her. Maybe she can feel more comfortable. So that is something that you need to be aware of, and giving support is extremely important. And you need to maintain a proper body language. Okay, you need to be empathetic, but it's not that you're going on saying that I'm so sorry to give you this news, I'm so sorry to give you this news. Not that way. Okay, you have given the news and you're open that it is a cancer. Just wait, give few seconds, give few pauses. Okay. And then allow her to react, and based on that you can take forward your consultation, like offering tissues or offering water, the routine, how we follow the pattern. You can do that as well. And don't use any kind of euphemisms, like just saying that, there is some kind of sinister changes, I'm afraid to tell you. No need. Just be open and honest that, I'm so very sorry, but the result has come out to be that it's a cancer ovary or cancer of the womb, whatever it is. I'm so very sorry to be bearing this news to you. I'm so very sorry to be the bearer of this news. Something like that. You can use different sentences, use a mix of sentences and convey. Okay, don't say that it is sinister changes or maybe it can be a cancer or not. You need not beat around the bush. If it's a cancer, you need to be honest that it's a cancer, because patient safety is a priority, and you need to be very honest to the patient when it has turned out into a cancer. Okay, and when you tell her that, we will be giving you these drugs, and then we give you 3 weeks time, and then we'll be again giving you some kind of medicines. This is called carboplatin, this is called paclitaxel, this is called cisplatin. Or if you try and use a lot of words, they would definitely get confused. You just say that we'll be giving you certain medications that will be running through the vein in your arm, and there are certain side effects which are expected to this, and whatever the side effects with terms of the chemotherapy, you have to tell. And radiation also, don't say that we'll give external beam radiotherapy, or we'll be giving brachytherapy, and we'll be giving at this point A or point B. Don't tell all of that, because the role player herself would be confused, because the first stage is to break out the cancer news and to give an outline about the management. Sometimes just breaking the news could be a part of station. You need to read the agenda of the station. Like, what are you expected out of the station? Are you expected to just break the news? Are you expected to talk about the further investigations in management? You need to look into all of that, and based on that, you have to carry on your discussion. And always remember that we are at the level of ST5. So involvement of MDT and anything beyond our league should always be escalated to the MDT. However beautiful you compose the treatment to the patient, if you do not involve the MDT, then the patient safety scoring could get affected over there. So in general, if you have to look for the domains in terms of oncology, then taking a comprehensive history is very, very important. Once you already know that it is a cancer, you need not ask about any weight loss or loss of appetite and all. That makes no sense because it's already a cancer. If she is having any kind of pre-malignant lesion, yes, suppose it's a vulval intraepithelial neoplasia, yes, you may ask questions like that because sometimes there could be any occult cancers as well. We don't know, right? So in such cases, yes, you may absolutely go ahead, but please make sure that you have to tailor the answers according to the situation rather than going by the routine template. Okay, and ordering investigations and interpreting the reports, all of these would come under information gathering, right? You have to take history, you have to offer examination, investigations, reports, all of these. You're gathering information from all of this, right? Communication, as we have just discussed, being very sensitive, mellow down your tone, be very empathetic and offer support, which is very, very important. And colleagues communication, you need to understand the cancer pathway, NHS2-week referral pathway, which means that you're fast tracking the case immediately so as to have any further treatment for her to avoid any kind of delay in her treatment. That is to involve the MDT. Whoever is there in the part of MDT, it is important that you have to name all of them, especially if it's a structured discussion. And never forget to talk about the support groups, and never forget to talk about the Macmillan's nurses. And patient safety, you need to understand about the drug safety, about the treatment options. Giving safe prescription is very, very important. What is suitable to her? It's not that there are different management which is there and will give you this and all of that. You first give an outline and then tell that, currently this might not be very suitable to you, and this is going to be the option which is going to be suitable to you. And whichever is there, whichever she's, you think that that's going to be better for her, you have to give that. Always give an outline of the management options, and then you go forward with your discussion about which is most suitable to her. And apply clinical knowledge. It depends on how you're counseling the woman. That's all very, very important. And you have to explain about the follow-up. For example, if it's a vulval cancer, VIN, okay? If you don't talk about self-examination, if you do not utter the word called vulval specialist clinic, involvement of MDT and all of that, there are chances that the scores could go down, right? So talking about follow-up and all of that is very, very important. For that matter, even when there is any cervical cancer or any abnormal lesions, it's important that we'll have to be talking about the referral regarding the repeat test for HPV and all of that, where you call her for the recall as well, right? So it depends on all of that. And it's more of memory based. So it's important that you need to be very, very thorough with the entire pathway and having a knowledge about the guidelines, the British Society guidelines, as well as the FIGO guidelines. It's important that you'll have to be thorough with all of them as well. Not very much into detail, but at least the outline. For stage 1A1, what are you going to do? For stage 1B, what you'll do? Similarly, for endometrial cancer, for different stages, how are you going to manage? So that is something that you all need to be aware about. I hope this initial introduction was clear. And let's look into a few cases. We've included about 3 cases, and we'll look into each of these as in how we can solve these stations. Okay. So the first one is when you are given 2 minutes of time. Okay, there is possibility that you will be given like 3-4 papers. Sometimes only a single sheet of paper could be there outside the cubicle. Read that thoroughly. Okay, see that you are an ST5. What is the age of the patient? And name of the patient is also very, very important, because you cannot utter the patient's name in a different way because the role player would get offended. Okay, you have to be very sure and ask how they want to be addressed rather than you deciding how she wants to be called. So just ask like, may I confirm your name and age, and how would you like me to call you? These appear very, very basic, but unfortunately, some of the times we might go wrong in these basics as well. And she has been referred because of dyspeptic symptoms and bloating. So when she has been referred by the GP, you have to remember that you have to write back to the GP at the end, okay? And then check the domains that you're being tested upon. As you can see, all the 5 domains are being tested here. And then you can see that already the GP has done few investigations. That is CA125 is already done. And the ovarian cyst also, which has got some concerning features like multilocularity, and there is also like increased blood flow and all of that. And the uterus and the left appendix appears to be normal. The cyst is as big as about 8 centimeters, right? So CA125 is 120. And even though you're not very confident about the ultrasound features, if you take the menopausal score, that is coming to around 3. So 120 into 3, any which way it's more than 200, right? So you're not expected to say that the score is this much or that much, but all you need to say is that, beyond a certain threshold, the score, when it is more, then we'll have to be referring to the MDT. That is how you have to counsel the patient. And what is the agenda of the station? That you have to take a focused history, you have to discuss the reports with her and explain the suspected diagnosis, because in this case, the working diagnosis is going in terms of an ovarian cancer. It could be because of her age and because of the CA125, because of the features of the cyst, that there is a strong blood flow and all of that. and further management options you're supposed to describe it. So in the first 2 minutes, this is something that you need to gather: the age of the patient, the domains, what you're expected to deal with in the station, and you've got some reports where you're supposed to interpret the reports correctly. That is very, very important. Patient safety and information gathering as well, right? So once you open the station, you can just ask, that I can see that your GP has, undertaken some tests for you in here to discuss about the results. Okay. Has anybody told anything? Are you aware about anything about your reports? And then say, like, could you tell me in your own words, like, why exactly the GP had to take few tests? If she's repeatedly telling that, I'm very anxious, doctor, just go ahead and discuss the report. Please go ahead and discuss the report rather than saying, I will discuss about it shortly, may I ask you a few questions. That's not the way. You have to satisfy the patient. If the patient wants the reports, go ahead and discuss the reports. If she's comfortable talking to you with the history, please go ahead in that direction. Always you have to cater to the patient. It's not about how much you know, it's about what the patient wants to know. And you have to talk in terms of like what the patient's requirement is, right? And when you put an open question, she'll be telling you that she's got such and such symptoms, because of which, the GP has told about the investigations. And then when you talk about the symptoms, you can just ask like about since when she's been having these symptoms. And then you ask about the pain. Okay, if she's got any kind, if she's telling that she's having some pain, you need to ask about the details of the pain. When she's already telling you that the pain is very bad and I'm unable to tolerate or something like that, you need not say, can you score the pain on a scale of 0 to 10? Okay, because that doesn't fit well. She's already telling you that she's affected by that. Okay, so always, as I told you, just tailor your answers according to her responses rather than going by the template. Okay, and since you are suspecting an ovarian cancer, yes, you may ask about the lack of appetite and weight loss, if she's got any altered bowel bladder habits, any discharge, any postmenopausal bleeding, and all of the routine history taking you need to ask about. Okay, in general, the entire history, and you have to offer the examination. Suppose the GP has already given that he's examined and the findings are already attached, you can refrain yourself from examining the patient. But otherwise, you have to offer the examination because you also have to understand what this case is all about, right? And then when you're explaining the diagram, when you're explaining the management, and then just tell that I've confirmed the name and the NHS number. Okay, and there is a blood hormone, which is, that's a protein which is usually secreted whenever there is any kind of cyst, but there could be different possibilities why, this hormone could be raised, but it appears a bit concerning, and which is normally expected to be around, like sometimes these cutoff could be 30 or 35, we don't know. So based on that, you have to say that, the upper limit is for this, but I'm afraid that it's about 120, and I will be explaining what that exactly means. I'll be explaining it shortly. And let me draw a diagram, and then draw a womb and then the ovaries and the tubes, and say that there is a big cyst in this as well. And what we're really worried about is we calculate a score, and based on which, it appears and that there is a high suspicion that it could be a cancer. You need to break out the news. And then she might be, very, very, she might be taken aback or something. In that case, then you can say that, please don't worry, we are there with you in this journey. Firstly, what we'll be doing is you'll be managed by a team, and you would be referred under 2 weeks to a specialist team who will be dealing with your condition. And what we'll be doing is we'll have to be offering for a CT scan. That is very, very important to have a better picture of the cyst, and we'll also be seeing to the other structures which are present in the tummy as well. And after the scan, we'll be referring you to the specialist team of doctors who can be deciding about what exact management can be performed on you. And it's also important that we'll have to be running a few blood tests to check for the strength of your blood, to see how your kidneys and how your liver is working and all of that. And with success, most of the women, they would be requiring a surgery wherein the womb along with the tubes and the ovaries would have to be required to be removed. Okay, just see whether she's in a position to take about all of that or not, or whether she's just enough with breaking the bad news. Okay, just telling about that. Otherwise, don't overload her with the information. I've given the entire table because if the station comes in any which way, you should be able to solve. But sometimes you might not be required to talk about all of this. It only depends upon how the patient is responding. Then you talk about the staging laparotomy, that the structures and the whatever is appearing suspicious, we might have to remove them and send them for testing. And sometimes, few women might be requiring further therapy as well. Okay, for the treatment might also be required even after the surgery. Depends upon the staging. Okay, I'm so very sorry to be giving you this news. And how are you going to go home right now? Okay, just as a matter of concern, if she's got some support, who's going to go accompany her to go home, right? It's just as a matter of communication. Okay, and try and be very, very empathetic. Avoid jargons that there is a blood flow or whatever it is. Okay, just say that, this cyst, there are some features which appear to be suspicious. And I'm so very sorry to tell you that, these are that there is a high chance that it could be an ovarian cancer. If you tell what an ovary is, you need not say egg basket, egg basket. Just say that these are the ovaries from which the eggs are produced and there is a cyst on this, and then you can tell about the ovarian cyst. Okay, and And next, try and explain it in a very smooth way as possible. Use diagrams wherever possible. At the end, always give the leaflets and have a very empathetic approach, and be very, very sensitive. If you don't involve the MDT, then the entire station could be gone in terms of patient safety as well, because escalating to MDT is not just communication with colleagues, but it is also patient safety. And information gathering, as we've just discussed, take the entire history template. It is very, very important. And then patient safety, as you all know, that we have to rule out allergies. That is very, very important. And if she's got any kind of like comorbidities, we need to do that as well. And interpreting the result correctly, that is again very, very important. And whatever the reports are given to you, okay, and then escalating it to the MDT, okay, escalating to the seniors, escalating to the MDT, and all of this is very, very important, okay. And if she's got any kind of comorbidities, as I told you, you need to address about that as well, okay. Just you need to you need to be like very, very specific that this could be like one of the possibilities. And apart from the cancer, you have to address about whatever the comorbidities, because that should not get diluted. That also needs to be addressed, and you have to put the proper, whoever is concerned with that particular specialty, you need to refer to them as well, okay. And ordering for investigations, always justify why you would want to order the investigations. It's not simply that you will be telling that I will do this and I will do that. Why do you want to do that? Because satisfying patient is the key at the end, and the patient must understand why exactly she has to go through the tests and through the scan, okay. And try and be very empathetic, and don't overwhelm with a lot of information. Just see what the patient exactly wants to know, and then go ahead with that. And next station is that you're an ST5, you're seeing a 29-year-old, which means that she's a young woman. She's undergone leads, and the biopsy is shown to be stage 1B1 squamous cell carcinoma. There is no lymphovascular invasion. The margins are also clear. And now here she's come to discuss about the management, and here we have got the 4 domains. Okay, sometimes they'll be giving you that she wants to discuss about fertility preservation, and sometimes majority of the history would be given to you that she's got no medical comorbidities or illness or whatever they would be giving. Otherwise, you have to take a good history. And always remember that whenever a patient has undergone any kind of procedure, make it a habit to ask, how are you recovering after the procedure? Whether it's amniocentesis or chorionic villus sampling, or whether it's Leeds procedure, whether it's a biopsy, hysteroscopy, anything, any procedure, just ask at the very beginning of the station. I see that you went on a procedure. Can you tell me, like, how are you doing after that? Any problems at all? Like any pain or any discharge? Just ask one after the other, okay? Question, don't club everything. I'm just telling it to you, put it in a single sentence, but otherwise you have to ask it one after the other. And ask about how is she recovering after that. And then, because here nothing is given, you have to ask about her future fertility plans and all of that, okay. 29-year-old, just because she's young, don't assume that, okay, she might be requiring kids and you directly talk about fertility preservation. We do not know, each woman is different. So always take the entire history, and you can ask about her past smears as well, like was this the first time that she is undergoing the biopsy, or prior also did she undergo anything, and was it pre-malignant, and did she receive any treatment, and now that has come out to be malignant. Asking about past smears is also very, very important. And then the routine history taking, we take the entire template, okay. And then you have to be open and honest with her. As I've told you, I'm not going to repeat myself and bore you all. So just be very sensitive and empathetic, and tell her openly that it has come out to be a cancer. But fortunately, there has been no spread. Okay, currently there is no spread to the other organs, and it has come out to be negative. And but yes, there is a cancer that has been detected of the cervix. Okay. And when such staging is given, you should be able to understand like what exactly. Sometimes they would be just giving you that these and these were the findings on the biopsy or whatever. In such cases, you should be able to decode the stage as well. Okay, if it's a structured discussion, especially. And then you know that if it is stage 1B1, again, informing the MDT, the NHS 2-week referral pathway, informing the oncologist and all that is in consultant is very, very important. Whenever you know that there is any stage of cancer, if it is stage 1A1, of course, the lymph node involvement is going to be less. So therefore, need for lymph node assessment is not required. But in stage 1A2 also, there is a possibility that there could be lymph node involvement. So therefore, lymph node assessment is required beyond 1A2. So 1B1 definitely requires a lymph node assessment. So you need to understand what exactly, the lymph nodes are involved or not. And that sampling would be done. And then you have to give her different options. Like you can give a conservative option as well. That is again, because the margins are clear, having a vigilant follow-up. Then again, you can speak about the conizations only, okay? Repeatedly, we can do the next conization and all of that. And we can avoid doing surgeries like radical trachelectomy, okay? You can discuss about like simple trachelectomy as well as in the conizations. But when she's undergoing the radical trachelectomy, you have to make her understand that there is a possibility of having like spontaneous second trimester miscarriages, as well as preterm labor and PPROM, and all of these risks needs to be explained to the woman, because she might, when she's young, she might be, willing to preserve the fertility, right? So you don't talk about the radical hysterectomy or all of that. Just talk about the fertility preserving options only. Like you need to understand about the lymph node staging. That is very, very important to check for the lymph nodes. And then you speak about the, that pelvic lymphadenectomy also can be done if the lymph nodes come out to be positive. And next we'll be talking about the conservative management. Okay. And lymph node assessment plus the radical trachelectomy, they can be done in the same sitting. And the recurrences needs to be explained to her. Whatever it is, you have to be very honest about the recurrences, that even though it might, we would treat it and we will be giving you the treatment, there is a possibility that it would come back. Okay, that is something that you need to be honest about. And then the communication with patient, as we have just discussed, it's going to be very similar, to have a sensitive and empathetic communication, and draw diagrams wherever it is applicable and attached to the support groups is very important, and giving her the leaflets regarding her condition is also again very, very important, right? And then we come to the final station for today, which is that you are an ST5 and you're seeing a 37-year-old woman, and again a middle-aged woman. She has undergone a vulval biopsy that has come out to be Win3. She's a known case of HIV. This is there. She's on antiretrovirals. She smokes about 10 to 15 cigarettes per day and has come to discuss about the further treatment options. This is a very, very important station. Okay. And when you read the domains, you know that you're being tested on 4 domains, right? So here there are high risk factors, that she is a case of HIV. How did she acquire that? We are not sure. Then she's got cigarettes. She smokes about 10 to 15 cigarettes a day. And then you need to check for the compliance of HIV as well. Since she has undergone the biopsy, of course, you'll be opening the station by asking, how is she doing after the biopsy? And what I usually suggest is to do the breaking bad news first, because you need to get it out of your way, and then she'll be comfortable to talk to your questions, rather than saying, can I ask you a few questions? And then she'll be repeatedly telling that I'm anxious. But of course, it depends. Some patients would be like, yes, you may ask me a few questions. But some patients would be like, I've undergone a procedure and I'm really worried. So maybe can you discuss about the reports? So it depends case to case basis. So you can just ask about how is she doing after the biopsy and what exactly had led to the biopsy. What symptoms was she experiencing, like itching, soreness, and in this case, you can ask about loss of weight and lack of appetite, bowel bladder disturbances. Most important in this, to ask about the quality of life and sexual life, because that's getting hampered in most of the cases. So you need to speak about that as well, which is very, very important. And then come to her HIV. Ask when was she diagnosed? Okay, did she receive any blood transfusions or any kind of like drug abuse in the past? Okay, you can ask about that so as to understand like what could be the possible reason. And then you can ask about about her compliance with the treatment, and then when was her last HIV, the viral load check done, whether she is in contact with the HIV physician or not. Okay, all of these you need to ask about that. Addressing smoking is again very, very important, and just say that you don't want to sound judgmental, but yes, this could be one of the risk factors where it might turn into a cancer. Because it compromises the immunity of one's body, that is the defense mechanism gets affected, and because of which the chances to cancer could be a bit high. Okay, that's how you need to ask about. And asking about whenever there is win, it can be associated with sin. So asking about smears is very, very important in the stations. And then the routine history taking. When you open the news, you tell that it's an abnormal condition. Start using certain kind of adjectives like it is an abnormal, an unusual, or sadly this is something that we have not expected that it has come out to be like this. Okay, you have to tell that that there are some abnormal changes in the skin of the vulva, but for the present it is not a cancer. But I'm sorry to say that if not treated on time, there are high chances that it could be turning into a cancer. And then keeping the addressing about smoking, keeping the HIV under control, all of this is again very, very important, right? And then you talk about the different kinds of management that you will be speaking about, and the NHS to weak referral pathway and escalating to MDT. That is all again very, very important. And then you have to order for a colposcopy. This is again very, very important. Talking about colposcopy, anoscopy, if at all there are any kind of perianal lesions, then you give different management. Like there are different ways how we could manage this. We have got medical management as well as surgical management. In the medical management, we've got different creams like MEDIC-MRCOG cream, and the Cytofover is of course still only for the research purposes, but it is not given clinically, and you have to say that it is unlicensed. What are the side effects which are expected when you use MEDIC-MRCOG, and how long you're supposed to use it? Okay, and clinically definitely there is going to be an improvement with that, but most of the women, they discontinue owing to the side effects. And photodynamic therapy is something that you can talk about. Talk about laser ablation. Okay, we use a laser to just burn down the area, and we will be getting the sample, so that can also be sent for testing again. Wherein we can understand if there is any kind of hidden cancer which is there. Okay, and if it is turning into a cancer, of course the surgery is going to be the mainstay of treatment in such cases, right? And you have to be very honest about the cancer. risk, and also because of the high risk factors that she is posing. And talking about follow-up is very, very important. And talking about the vulval clinic, the specialist vulval clinic is very, very important, that she has to be doing like 6 monthly follow-ups the first 2 years. And then you'll have to be doing annual follow-ups for 5 years. That is again very important because it may come back, and chances of turning into cancer is also high, especially whenever the individual is immunocompromised. Okay, so you need to be honest about that and try and see how much the patient is able to take, and then you have to tailor your answers accordingly. So if I have to summarize once again oncology, I will take about 30 seconds to summarize. What I would tell you is try and be very, very empathetic, try and be sensitive, and don't overload a lot of information. Try and see what exactly she wants, and that is how you're supposed to counsel the woman. It's all about how you're communicating, and it can come as a lay examiner station. So you're being tested upon communication rather than telling that cisplatin, carboplatin, etc., how many cycles and all of that. Just give basic, like what are the side effects which are expected, when she might be requiring a radiotherapy. Involvement of MDT is again key, and don't forget to talk about the follow-up as well as the risk of recurrences in any kind of cancer. Okay, I hope you found this video useful. If you've got any doubts, you can let me know in the comments below. Happy studying.